this discussion, we will be concentrating on a few presentations of peripheral vascular disease. So take a while and look at this case history. So the points that we have to grasp here is that the pain is in the right leg and it is 3 months. So we have to think of chronic pathologies. So one of the commonest cause for pain anywhere is acute inflammation, which is here it is we are not going to consider that. So all acute inflammatory pathologies are out. And also it is in a 45-year-old male. So we have to think of diseases which are more prevalent in the middle age and the elderly people. So in order to look at what is the pathology, and we know other causes of pain anywhere in the body, as I said, one is a common thing is acute inflammation, another one is trauma. So here again trauma is not of concern. And then uh, vascular pathologies, so it's possible here. And also any problem of nerve irritation can cause chronic pains. So anyway, so this should be in our back of mind when we see this type of history. And so it's 3 months, and it's very important when a pain is 3 months to any problem. Look at the time frame. Is it there all the day, or at particular times, or is it just it has some periodicity? So in this patient, that would be the first inquiry. And when he was asked, he said that it is there when he walks, and when he walks he get the pain, and when he stops walking or when he rests, the pain will settle, and then when he walk again he'll get the pain. So this is typical of a intermittent claudication. And so with that we have to look at the possible differential diagnosis for this patient. So one common thing is, of course, arterial, which is actually most commonly when we say intermittent claudication, this is what it comes to our mind. But it's a arterial claudication due to a peripheral vascular disease. So the vessels are narrowed, so the blood supply is not adequate when he exercise, and he gets the pain. And then when he rests, then the blood flow becomes all right for the rest sitting, so pain disappear and he can walk again, but it will come back. And also it could be a venous claudication, which happens most of the time with deep vein thrombosis rather than the superficial varicose veins. Venous claudication generally happens with a deep vein thrombosis. And also another one would be a neurogenic claudication due to lumbar canal stenosis. This is also possible when he walk, and whether it's any musculoskeletal, like some arthritis. So how are you going to find out? So what are the things? Now arterial claudication, when he walk he gets, and when he rests it settle. Now we look at neurogenic first. Now neurogenic claudication also, when the person walk he can get the pain, and resting it will relieve. But the important differences between these two is arterial claudication he get the relief when he just stands, it is adequate. But neurogenic, generally he has to sit, or at least bending forwards is more relieving. So it's one important point. Both will settle when they stop, but arterial claudication standing is adequate. But neurogenic, they either have to sit or bend forwards. And also the arterial claudication, the pain is mostly below knee. Mostly below knee, because it's the distal part which gets more ischemic. The neurogenic claudication, it tends to be above knee most of the time. And also arterial claudication will be worse when they go uphill, but neurogenic claudication, they it may be less when they walk uphill. And also arterial claudication, it settles quicker when they rest than the neurogenic claudication, so easily you can distinguish. And the venous claudication, even when when they stand for long periods, they can get this very throbbing type of severe pain. Some venous claudications again, they can come when the person walks, and when he rests the pain will disappear, but it takes quite a while for it to settle, because even with the standing still the venous stagnation is there. And also there will be enough other evidence of venous congestion like edematous leg and other forms of things like eczema, ulcers, skin changes, so those also will be there. So this patient that we are talking today, he had typical features of arterial claudication. When he walk, he get the pain. When he rest, just standing is adequate, it settles and then it comes back. So what are the things that we have to further find in this patient? One thing is the claudication distance the patient is having. The claudication distance the patient is having, because it will tell you how disabling this problem is for the patient. And then also the progression is important, whether it is getting worse with time or whether after some time it settles. And some people may think even it got settled and maybe even slightly improved. But how can it just one thing is going down, progressing, we can understand the disease process progresses with continuing arterial occlusion. But how can they come to a settlement where they have the symptoms but it won't get worse? Or few people may think it's slightly better. This is by development of collateral circulation. By development of collateral circulation, it can happen. And also with time, another thing which can happen is the patient can get adjusted to the problem, and they learn to walk slowly, and then they can walk a longer distance, and also they get used to this stopping and going, and they may think that it is better in that sense also, because they get used to that. And also they may use some other modes of to travel, like a vehicle, and he does the home the work at home with slow walking, so this may be there, but quite a number may just get worse and worse. And then the site of the pain is important. Now the person I'm presenting today, he said his pain is in the right calf. So what is the importance of this? If the pain is in the right calf, that means his occlusion is in the artery which supplies the entire calf. So that has to be the superficial femoral artery, or maybe the popliteal. So if you recall the arterial supply coming to the lower limb, the aorta bifurcates into the two common iliacs, and then it divides into the internal iliac, which is supply from the pelvis, and the external iliac will continue. And once it crosses the inguinal ligament, we call it the common femoral artery. Common femoral is because it's common to supply the entire lower limb. And the common femoral divides into the profunda femoris and the superficial femoral artery. And the profunda femoris is also named as deep femoral. The profunda femoris is the supply to the thigh, and the superficial femoral artery is the supply of the leg below the knee. So therefore the superficial femoral artery doesn't give any branches in the thigh. So, and also another point is, even though it is called the superficial femoral artery, it is not a superficial artery. You can't feel the pulse of the superficial femoral artery. It's covered under the sartorius. But why we call it the superficial femoral is because simply because it is superficial in relation to the deep femoral or the profunda femoris artery. But anyway, coming back, so this person had pain in the calf. So his occlusion has to be in the superficial or the femoral artery. Supposing there is another patient, he says he has pain in the calf and also he has pain in the thigh. Then what is the artery occluded? Then it has to be the common femoral because the entire leg is affected, the calf and the thigh. Supposing he says he has buttock pain also, that means the occlusion is in the iliac vessels, or it may be the entire aorta iliac segment. In that case, they will have bilateral symptoms. So by the pain distribution, it is possible to guess what is the artery. So if the calf repeating like in the patient we are discussing, it has to be the superficial femoral or maybe the popliteal. If thigh and calf both, it is the common femoral. But if buttock pain is there, it has to be the lower aorta, aorta iliac, or maybe the iliac. So person with a buttock pain, if it's a male, you have to ask if the person has impotence also. But in this patient, it was only calf claudication. And also, the other thing is, what is the Fontaine grade? So Fontaine, there are four main grades. Number one is asymptomatic, two is intermittent claudication, three is rest pain, and four is gangrene or any form of tissue loss. So the person we are discussing today is in Fontaine grade 2. Yes, intermittent claudication. But even if person complains of intermittent claudication, it is important. It is important to ask whether he has rest pain, because only if we ask that he may recall this. So this patient today we are discussing, he denied any rest pain. In case if there is rest pain, you have to qualify more. You have to be certain, because sometimes people you ask, is there pain at rest? Also they will say yes. One thing is just to ask whether it disturbs the sleep. You ask, did you sleep well last night? The person in rest pain, invariably they say no, I can't just sleep. It's so painful. You ask, how is there anything which relieve? He will say, okay, yeah, when I put my leg down, it relieves. So you have to look ask for these features. So when coming back, the person we are discussing today, he had this intermittent claudication, which was arterial because it settled when he stands. And one point I have to mention again is the neurogenic claudication, where with standing alone it may not settle. Either they have to bend forward or sit. So this sometimes these people, sometimes this is called as the shopping cart sign, because in shopping malls you have these carts to push, and when you push you lean a little bit forward. So of course just a name it just come. Anyway, so coming back to this patient, so he has intermittent claudication in the calf, and it's in Fontaine grade 1, and his claudication distance was about 50 meters, and he said it was gradually, little by little, the claudication was distance was getting less. So he had a bit of a progressive disease. And so by the calf pain, we know his possible occlusion is in the superficial femoral artery. So this is the history of the presenting complaint. In that, important things to evaluate are the disability the person has and put him into the correct Fontaine grade, and then the site of the pain, which will tell you what is the artery occluded, and the progression of the disease. These are the important things, the initial history of the presenting complaint. And then we get into the systemic inquiry. And earlier in my discussion, I said there are two reasons why we take the systemic inquiry: whether the pathology can affect the other systems. That is one you have to evaluate, and the second thing is you evaluate the other systems in general, because you are treating a person. And so this is a vascular disease. Most of the time it is due to atherosclerosis, but you can read up and see what are the other pathologies which can cause occlusive arterial disease, and it can affect the other parts of the cardiovascular system. So in your systemic inquiry, this is one thing that you have to go to assess. So heart, the heart vessels get involved, they can have a history of angina, and also they can have features of cardiac failure like shortness of breath on exertion, orthopnea, paroxysmal nocturnal dyspnea, edemas, right hypochondrial pain due to liver congestion. So this is important. And then of course also you get some respiratory inquiry, because these people are smokers most of the time. So they may have evidence of chronic cough, for example. And then the cerebral circulation. So in the history you have to ask whether they had any history suggestion of a transient ischemic attack or even strokes. And then also your intestinal secretion, the mesenteric blood vessels may get occluded. So they can have what is called mesenteric angina, where they experience a cramping type of abdominal pain after a meal. And also your renal arteries can get stenosis. So they may go into evidence of chronic renal failure. So you have to ask history of like polyuria. So this is important, the systemic inquiry. Then past medical history. So the person may be already diagnosed of ischemic heart disease and other things which may predispose the patient into peripheral vascular disease like diabetes. And also you have to ask about hypertension, hyperlipidemia. So the past medical history is very important. And then the past surgical history, whether he has undergone any interventions for this current pathology or also any other surgeries. Social history very important, because one thing is smoking, which is a known predisposed to peripheral vascular disease, and also his occupation, whether walking, whether its occupation involved with a lot of walking, then the disability is more. If he has a sedentary job where he travels by vehicle, he may be not that bothered. And also his earning, how much his occupation is suffered by the symptoms. So this is very important to assess this. And also family history is important, and also your drug history and allergies are also equally important. Like say if the person has allergies, if you're going to do any contrast investigations like angiogram, that becomes important. So you do a full evaluation of the patient. So coming back to our patient who presented with the intermittent claudication affecting the calf, it says that it's likely artery occlusion in the superficial femoral artery, and his claudication distance was about 50 meters, and he had a gradually worsening symptoms, and he was a person who was on treatment for hypertension and no surgery in the past. He was a smoker. He smoked for nearly 20 years, and uh, otherwise there was nothing significant. Other than that, there was nothing significant, more significant in the history. So now we have a diagnosis in the hand: intermittent claudication due to occlusion of the right superficial artery, possibly on the history. And he's a smoker and also on treatment for hypertension. So examination will confirm the diagnosis. So you have to check all the superficial pulses which you can palpate, like the radial, the brachial, femoral, popliteal, posterior tibial, and the dorsalis pedis. Pulses you have to look for. So this patient, he had upper limb pulses are normal and bilateral femoral pulses were normal. Right side and left sides both, the popliteal pulses are absent and all distal pulses were absent. So clinically our diagnosis is confirmed because his popliteal is palpable and normal, popliteal absent. So therefore the diagnosis of superficial femoral artery occlusion is correct. And also this person, even though he didn't have symptoms on the left side, even that side there's some occlusion in the superficial femoral artery. But why doesn't he get symptoms on the left side? Possibly because right side is occluded more, and he gets the pain in the right leg and he stops, and the symptoms on the left side is masked. So that can happen. But sometimes this side may be normal. And then look for bruise or listen for a bruise like subclavian, carotid, aortic, renal, because these vessels also may be blocked. Say the person may be having a carotid bruise and you are going to diagnose it clinically first time, even though still he has not got any TIA. And also look for bruise over the iliac vessels and the femoral artery, because if the bruise is there, you can say, okay, this side is a point of occlusion. He didn't have it. The person we are discussing today didn't have any bruise. And look for aneurysms, aortic aneurysms, femoral and popliteal. It's very important because these cases of chronic occlusion are due to atherosclerosis, and aneurysms known complication of atherosclerosis. So look for that. And also end organ effects. So here we have a person with the ischemia of the right leg. So look for any like skin changes, hair loss, feel for the temperature and see. And also say like carotid, if it's a diagnosed case of past stroke, check his functions of what whether he has got a recovery from the past damage. And so our patient, again summarizing, intermittent claudication of the affecting the calf, and clinical examination of pulses confirmed because femoral is palpable and the popliteal is absent, and there were no bruise, no aneurysms. And then of course he had some skin changes with some hair loss. And also it's important to look at the veins of the leg, because if the ischemia is severe, usually your veins won't be filled. But in a person with an intermittent claudication, if you see nicely filled veins, then of course the blood supply has to be of some adequacy. So this patient now clinically we have diagnosed a superficial femoral artery occlusion and is in Fontaine grade 1 disability. So in a vascular, peripheral vascular disease history and examination, the important highlights would be initially you establish the disability by putting to a Fontaine grade, and also the site of occlusion by the history, and then a global vascular system history of cardiac, cerebral, mesenteric, and also renal. And then in the balance of the history, look for any etiological factors like smoking, hyperlipidemias, diabetes, hypertension, because these things, if you identify, you can modulate for the patient. You can either treat and get them control, or like smoking, you can ask the patient to stop, because then the disease progression you can halt. So now the next stage is investigation. So what are the investigations that we are going to do to confirm the diagnosis? So first, this patient we did a ankle brachial pressure index, and you can see here how the ankle pressure is taken with a normal blood pressure. So when with a cuff you inflate, and while deflating, because here now we said the pulses are not palpable, so only way that with the Doppler you can check when the signals are coming back, and that's the systolic pressure of the calf. Uh, and then you do the for the with the brachial artery, put the cuff on the arm and measure the brachial systolic pressure, and you divide the ankle pressure by the brachial pressure, and in a normal person it has to be above 1, but up to 0.9 we take it as all right, but below 0.9 it is low. So this person's ABPI was 0.5. So these are the usual figure that range that you generally see in intermittent claudication, below 9, and it will be generally about like point 0.3, point 0.4. Who drops below zero point 0.4 are likely to be in more worse uh, ischemia, which are rest pain and the either gangrene or tissue loss. So the rest pain and the gangrene or tissue loss are classified as critical ischemia, because critical ischemia means that you have a very high risk for very early limb loss. But of course, it's very important to remember that you classify either as critical ischemia as which are either based on rest pain or gangrene, and it is by the symptoms, not by the ABPI. But I'm just telling ABPI correlations because we have to remember that sometimes you can get faulty high ABPI results, especially in a diabetic, where if the vessels gets calcified, you may get a falsely high result. So it's a bit of a crude index, but it's good bedside test, and there are various other uh, importance of measuring the arterial duplex, which I'll discuss along with the presentation. And now, and then we did a arterial duplex, which is a non-invasive investigation, and it confirmed that there is a occlusion in the right superficial femoral artery and also on the left side, but the flows are more affected on the right side. Beyond the occlusion, flows are more affected on the right side. So now, other more detailed evaluations, digital subtraction angiography, still people tend to consider it as the gold standard investigation, where you can get a lot of details. And arterial duplex, it's a non-invasive, therefore it's very good, but of course it's operator dependent. So double DSA is considered as gold standard by many, but of course disadvantage is you have to prick the femoral artery. So in our hospital, we do the CTU angio because there is no puncture of the artery, and also MR angio is available. So, but this patient we didn't embark on a CT angio because he was only in intermittent claudication. So people with intermittent claudication, uh, you can manage them medically and see whether they get an improvement. You're not going to embark on surgery or any other intervention in a rush in an intermittent claudication. So he was started on aspirin. His hypertension was treated. He was also started on statins, and he was asked to do a regular daily walking program. And then we got arterial, the ABPI measured, uh, which was zero point 0.7, and then we reviewed the patient in the clinic uh, to continue the medication. And then how do you see whether what is the situation of the patient? One thing, the symptom inquiry. So the person may either say, okay, I'm okay, I can manage, or he may say, now it's getting worse. And also you can measure the ABPI again because it's for the same patient. So that's why I said the ABPI has a very importance more than the initial diagnosis in the follow-up. So if the ABPI remains all right, nothing to worry. But this person's ABPI had dropped to zero point 0.5 by after 6 months, and he said the pain is getting worse and it's really troubling his day-to-day work. So therefore, we thought that he made it an intervention, and so we proceeded to do a CT angiogram on this patient. So this was the angiogram of this patient. Of course, here the angio what I displayed. So here you can see actually the occlusion is on the left side. So even the person I was presenting the history was the right side claudication, but the angio which was available me for discussion was this. But anyway, that's no problem. You can learn out of this. And what are the important things that you look in an angiogram or even a duplex? One thing is the site of occlusion. It's important. because if you're going to interfere, you should know where it is occluded, and also your clinical diagnosis will be confirmed. And here, without any doubt, it shows a superficial femoral artery occlusion. Here you can see right side superficial continuing, but here there's a discontinuity. And also the extent of occlusion. Here it's a complete, you can't see the vessel. And also because sometimes it may be a partial occlusion, and the length of occlusion is also important. The length of occlusion is important when you are deciding what type of intervention you're going to do. And then another one, you have to see whether there are collaterals, because this film, I don't know if you can see well, but of course there are collaterals. And one important thing is, if the collaterals are adequate, it should fill the distal vessels, which we call a good distal runoff. But it's very important to remember, but what we mean by good distal runoff is not, we are not telling the flow is adequate. Okay, flow may be adequate with collateral, but if the flow is adequate, he won't be symptomatic like this. So what we mean by a good distal runoff is that you have a patent vessel, because it's important to have this what is called the good distal runoff or good patent vessel, because if you are going to do some intervention like some bypass or angioplasty, you should have a distal patent vessel. Otherwise, your bypass is not going to work. You're going to put a graft from there to there. If the vessel is not patent, the blood can't flow. So these are very important things to look. So the person actually, he had right side symptoms, as angio would have shown this right superficial femoral artery occlusion. So important things again: site of occlusion, extent of occlusion, whether there are collaterals, and if you are going to interfere, there has to be a distal patent vessel. So thinking of these interventions, again I said intermittent claudication you can observe, but if the claudication is very severe on the first presentation, or it was not very severe, you're observing it getting worse, so those cases you can interfere. Probably that may be the best stage to do the surgery, but it's a very, you have to decide very carefully, because these surgeries are high risk surgeries, the patients are high risk, and also your graft can get occluded with time. So you should never do a intervention unnecessarily. Only if it is severe or it is getting worse, all intermittent claudication, it may be worth watching them on some time, get them to walk and see, there's no hurry. But if it's a critical limb ischemia like what you see here, he has already, the foot is getting gangrene. So either rest pain also is just pre-gangrenous, or he has gangrene or chronic ulcers which are not healing. They definitely need some form of intervention if the patient is fit enough. So the person we are presenting today, his occlusion was in the superficial femoral artery. So then he was planned for a femoropopliteal bypass, because his occlusion is in the superficial femoral artery. So you do a bypass from the femoral artery to the popliteal, femoropopliteal graft. And most of the time, and all, so like that, this patient, we use his own long saphenous vein as the conduit. So you can see this picture. So you will have this a long incision line, and here is to expose the popliteal artery, and popliteal artery may be exposed either supragenicular or infragenicular. It depends on where the vessel is patent. So if the artery is patent, more patent below the knee, you have to do a infragenicular exposure. But if you have a good popliteal artery above the knee, just after the adductor hiatus, you can do a supragenicular exposure, because if it's there, better to do there, because your graft, but your the length you have to harvest the vein will be less. And this patient, of course, had to go for a infragenicular bypass. So when you look at a person with a vascular history, if you see this incision, you can fairly guess that he has had a femoropopliteal bypass, and the superficial femoral the great saphenous vein has been harvested. And you actually see few incisions, and in between there is a the area where there is no incision gap, because you can actually tunnel under the without making large long one incision to harvest the graft vein. You may have bridges of skin, so the wound healing will be better. And what is the other type of graft you can use in this situation? You may use a artificial graft. If you use an artificial graft, of course you will not have this long incision of the vein harvest. You will have a incision in the groin for the femoral and around the knee, either supragenical or infragenical of the popliteal artery, and you just tunnel and take the graft. So it is less time consuming and less traumatic for the patient, but the disadvantages are that it's very costly. So a single lumen graft may cost about 100,000 Sri Lankan rupees. And also the risk of getting infection is higher with the artificial graft. So below knee infragenical, usually we tend to use the venous graft, but it depends. And also, so because the infection rate is high, by chance you have some wound, then of course always it's better to use the vein. So this patient again coming back came with intermittent claudication, and by the history we knew that the possible site is the superficial artery, and pulse examination confirmed, and his ABPI was 0.7, and the arterial duplex confirmed superficial artery occlusion. But we observed him for some time because he was still claudicant, not a critical ischemia, but he was getting worse, and the symptoms are troubling him. He couldn't work, and then we did this femoropopliteal bypass. Now, what is the other type of intervention which you can do for arterial occlusions? It is angioplasty and insertion of stent, and this you do even for cardiac ischemia. Rather than doing open bypass surgery, you can do angioplasty and stent. So similarly, lower limb, without doing a graft, the radiologists, they pass a guide wire, they do angioplasty, dilate the vessel, and also then place a stent. So what are the advantages of endovascular techniques? Because you will avoid all this long incision. So the long incision problems, pain, chance of infection, they are not there with endovascular, because there you puncture the femoral artery on the opposite side, get a guide wire across, and over the guide wire you're doing all this, sending the thing. So, and also here, while during the bypass, you have to clamp the femoral artery. Otherwise, it will start bleeding. So you clamp, and there will be some increased ischemia for the leg during that period. But endovascular, there is no vessel clamping. There is another big advantage of endovascular angioplasty and stenting. So, but of course, all occlusions you can't angioplasty. If it's very long, it is difficult. Earlier, only the short segment high flow parts like the iliac occlusions were angioplasty and stented, but now even longer suprafemoral artery occlusions are being handled. So that's why I said the length of the occlusion is also therefore important, and also the degree of occlusion. You should be able to get a guide wire across, but the radiologist uh, will decide on this. So you have to discuss the CT angio with them and see what is the best for the patient. Whether you are going to do a bypass or you are going to do a angioplasty and insertion of a stent. So this person coming with intermittent claudication, diagnosed to have superficial artery occlusion, was finally decided to have an intervention, and since the length of occlusion was long, he was planned and performed a femoropopliteal bypass. So this type of patients, you should know the pre-operative and post-operative care of these patients, like how to prepare for surgery, then feeding after surgery, mobilizing. Those are all important. But one point I have to make is, if you do a bypass or some angioplasty and stenting, after the procedure immediately do a ABPNC, because you will know whether the person has improved. Sometimes the pulses may also come back. That's good. Still, you get ABPI. It's very important because supposing after post-operative period, the first day, patient gets a sudden pain in the leg again. The possibility of graft occlusion is there. So immediately you do ABPI. If it had dropped drastically back to the previous level, or it may even fall worse than that, you know sudden occlusion has happened in the graft. So unless you do something, you may even the person may even go into gangrene of the leg. So therefore the ABPI is important. As I said earlier, in the intermittent claudication follow-up, in the clinics you do the ABPI regularly and see how it's changing. And again after surgery or uh, stent insertion, you do one immediately and you see whether it is improved. And it is improved. And again in the follow-up in the clinics, you discharge them on statins again, aspirin and walking. But you have to review them in the clinics because there's a possibility, and also ask them to stop smoking, because the graft can get occluded, but it won't get occluded suddenly in the follow-up phase. In the acute early surgery time, it can happen, sudden occlusion. But later, usually narrowing starts at the sites of anastomosis. And then it becomes worse, and once it closes beyond a critical level, when the flow in the graft ceases, the graft then it will clot and the graft will not function. So if a person comes to your clinic, and even if you, before he start getting symptoms, if you know the ABPI is going down, you can do a duplex and see. And if you see osteal narrowing, you can again do angio, and you may be able to salvage some with some angioplasty. So ABPI is a good way to follow up people. And this is another patient we had who had left side symptoms of calf pain, and he had thigh pain, and also he had buttock pain. So the clinical diagnosis was whether he has a iliac occlusion or aortoiliac segment occlusion, and the pulse examination confirmed he had absent pulses from femoral downwards both limbs. And again here, one leg symptoms he had because that side was worstly affected, so other side symptoms may be masked. So this is the angio he had. His artery aorta is occluded just beyond the renal arteries. But you can see again these lower limb vessels are reformed, so there's a good distal runoff. And this person presented in he had rest pain, so he was in critical ischemia. So he has to undergo a bypass, even though he's symptomatic only one side. It is wise to do a bypass to both limbs. So from aorta to both limbs. So therefore we call it a aorto bifemoral bypass. Aorto bifemoral bypass. But supposing if it is just one iliac occluded, you may do a aortofemoral on one side. But this one underwent a aorto bifemoral bypass. So something like that. You get a graft from aorta to both thing, and these of course always they are artificial grafts. Uh, One thing about vein, you can't that it's not enough to get a flow from the aorta down, and also it has to be two limbs. So these are artificial grafts, and you can see the artificial graft here after being anastomosed. Here the aortic end and the two ends going to the femoral artery. So aorta bifemoral bypass for this aortoiliac segment occlusions. And some patients they have distal vessel disease, like after the popliteal artery, or it may be the popliteal is occluded, or some vessels beyond the popliteal. But if there's a distal reformed artery, you can do a distal bypass from the femoral into either the anterior tibial, posterior tibial, or sometimes peroneal, but most easy we do to the anterior posterior tibial arteries. So just to sum up what we were talking, a person coming with intermittent claudication, it's easy to distinguish from either venous or neurogenic claudication, and you put him to the Fontaine grade depending on the symptoms, and Clinically, you can diagnose what artery is occluded by the history, where the pain of the claudication is there, and also by the examination of the pulses. And you get a BPI, which is mainly important for follow-up purposes, and then you image. If you're just going to medically manage, a arterial duplex will be enough. But if you're going to do some intervention, it is you need a angio, and because the DSA has invasive, we do a CT angio. And on the CT angio, important things to look at the site of occlusion, the extent of occlusion, including the length, and with their good collaterals, and when there's a good distal runoff, which means there's a patent vessel distally. And either so the indications for intervention will be mostly it is critical ischemia, either rest pain or gangrene or tissue loss or non-healing ulcers. But intermittent claudication, if it is very severe on presentation or you're observing it is getting worse, you may interfere. So it may be by a bypass or an angioplasty and stent insertion. Angioplasty and stent insertion, it causes much reduced morbidity to the patient. And bypass, it depends on what vessel is occluded, and the person we presented had a superficial femoral, so he had a femoropopliteal bypass, and we showed some examples of aortobifemoral grafts and also femorodistal grafts. And also there's one important thing. Now, a person with intermittent claudication due to arterial, so we know it's the distal most part is gets more ischemic. So if a person gets gangrene, it is usually the toes. If there's an ulcer which is non-healing, usually it will be in the foot. But the intermittent claudication pain they feel in the calf. That is because the bulk of the muscles are in the calf. Below the ankle, it's all the tendons. So the intermittent claudication pain will be in your calf. But when it comes to rest pain, then the pain is more in the foot. So it's one important point to remember. Then these are the few questions that it's better you think of. That when you are taking the history, a person may deny that he has symptoms of angina, but he has significant coronary artery occlusion. Is it possible? Person with significant coronary artery occlusion, but he doesn't have symptoms of angina. Just think how any explanation for that. Then the complications of doing a digital subtraction angiography. What are the complications and how to recognize and how to manage them. Then also pre-operative, post-operative care after bypass surgery. One thing, of course, uses ABP I have mentioned. Again, here I have highlighted here, but I already have discussed that. And also in your pre-operative evaluation, if a person has evidence of ischemic heart disease, where it causes a high risk for surgery, and that type of patient, how we are going to manage? If the decision is made that if you do the surgery with anesthesia, he has a high risk of getting a cardiac event. So what are you to do? Because if you don't do the bypass, he may get the limb gangrenous. So in this type of patient, what is the management? Then one endovascular technique I discussed is the angioplasty and stenting. What are the other forms of endovascular techniques available? Then I said the artificial grafts has a higher rate of infection. And how does artificial graft infection manifest? And also this is a chronic arterial occlusion, but critical limb ischemia. Sudden occlusions, what are the causes and how to identify the one cause from another and the managements. So it's important to think of all this, and all these things I have discussed in the notes I have given as this for these ward discussions. So first you think about them independently and you refer to the notes and you just see whether you have worked out the correct answer.